Okay. All right, we're going to get started. Good morning. Thank you for having me here at Pediatrics Grand Rounds. And thank you for the introduction. Okay, so a reminder to get credit for attendance, do the following on the screen. Disclosures, so I work for Maine Behavioral Healthcare, which is part of Maine Health, and I also have research funding from several organizations, and I'm on the board of a nonprofit National Council on Severe Autism. So our learning objectives today are to identify characteristics of challenging behavior in youth with autism, appreciate how you build a program of clinical research, and identify the application of artificial intelligence, or see an example of how you apply artificial intelligence to a clinical problem. So the way we'll do that is first we'll talk about challenging behavior in autism. Then we'll talk about emotion regulation and arousal in autism. Talk a little bit about research program development. And then I'll share some data with you from studies we're doing where we're using physiologic measures and artificial intelligence to try to have a different approach to aggression in this population. And then at the end, I'll have show some resources, both national and local, for those of you who are encountering this population, and hopefully certainly have some time for questions. So some information that may be familiar to many of you. So autism, roughly 1% of the world population, give or take. And recent estimate from the CDC, based on a survey of 8-year-olds looking at medical records, was 1 out of 54 in the United States. As has been the case for many decades, autism continues to be shown as 3 to 4 times more common in boys than girls. And so if you take that 1% number, there's more than 3.5 million Americans in the US living with autism. Here in Maine, from the Maine Kids Count survey from 2019, there are over 7,500 children ages 3 to 17 who are identified with autism in Maine. So within autism, there is an issue that is what brings this population often to the behavioral health care system, and certainly also to the primary care office, and that is difficulties with challenging behavior. And there's a range of what we call challenging behavior, but the most problematic, of course, are those that affect safety or present safety risks. And so the primary examples of that being aggression, which is physical aggression toward other people, or self-injury, self-injurious behavior, which is hitting oneself, biting oneself, etc. And this is a very significant issue in autism, unfortunately. So what I'm showing you here are several estimates or studies. So a study of in the community of aggression and self-injury prevalence. So this, importantly, was a community study. It was looking, it was kids who were identified in their IEP as having autism. So this was not a clinically referred sample. This was really a community sample. And so theoretically, these are just kids in the community who, you hope are doing okay. Well, in that group, 5% had physical aggression currently at that point in time, and 11% had self-injurious behavior. So that, I think, is quite significant. Then when you move to a clinically referred population, so if you move to an outpatient clinic, you're going to see 10 to 40% of the population having these problems. And then certainly if you move to a highly specialized setting, such as the unit at Spring Harbor Hospital that I'm going to tell you a little bit about, where the reason kids are referred is because of aggression, self-injury, and other challenges, you're going to see, we see very high rates, 80 to 90% with aggression, 20 to 25% with self-injurious behavior. One thing I'll just note about the self-injury is This is not the self-injury you see in adolescence that's called non-suicidal self-injury, and NSSI, which is also known, often is cutting, right, or scratching oneself, which you often see or you tend to see in an adolescent neurotypical population. This is not that. This is self-injurious behavior, hitting oneself, biting oneself, etc. You can see that other form of self-injury in high-functioning youth with autism occasionally, but it is not a major feature. So how do we think about aggression and self-injury in autism? And you can use the same thought process really for any youth who is developmentally delayed, but we're focusing on autism today. So how do we think about this? Well, they are not disorders. They are not diagnoses. They're just symptoms. When you look at the criteria for autism, it does not say a word about aggression or self-injury. In other words, it is not part of the disorder. It is something that can happen or can develop. So then the question is, well, why is this happening? And so in no particular order, mostly, there's a number of things that could be leading to this aggression or self-injury. So one is psychiatric comorbidity or co-occurrence. So in other words, people with autism who have a co-occurring psychiatric diagnoses. Most common, anxiety, followed by ADHD, followed by mood disorders, and then rarely psychosis and bipolar. Right, so those are, and the layout I just gave you of the prevalence or commonality of those psychiatric disorders actually matches the ranking in neurotypical youth, right? What's the most common psychiatric diagnosis in neurotypical youth? Anxiety. Second most common, ADHD, followed by mood. Most people think it's ADHD, but it's not. Anxiety is the most common psychiatric disorder in youth in America. So same order, however, the prevalence in autism is 3 to 4 times that of the neurotypical or typically developing youth population. So it's much more common to have these co-occurring disorders in autism than it is in kids who don't have autism. And of course, as I'm indicating, those disorders, if you're highly anxious or you have severe ADHD, et cetera, can contribute to these behaviors, these behavioral symptoms. The second major area is what the field of applied behavioral analysis tries to address, which is what function does this behavior serve? And how is it being reinforced and maintained by the environment? So that's a whole world and science. Other things that can contribute, communication problems, particularly functional communication problems, meaning can you spontaneously and independently ask for and get what you want or need? There's several words in there: independently, spontaneously, without prompting. So a child might be able to speak or communicate some, but can they speak in a functional way, or can they communicate in a functional way and get their needs met? If the answer is no, it puts them at significant risk for many of these problems. So we focus on communication quite a bit. Certainly side effects to medication are a big problem. Sedation is not helpful and often increases aggression and self-injury. And then there's a slew of other things, right, that could contribute to this. Just like all children, family changes. A new baby in the home, 8-year-old with autism suddenly is having difficulty. Of course they are. Just like the non-autism 8-year-old is going to have potentially some difficulty with a new baby in the home, and all the attention shifts to the baby, as it should, and no one's sleeping. Same thing for the child with autism who's 8 years old. So we look at family changes, sensory difficulties, and as we'll talk about, this population also has difficulty with emotion regulation. Sleep disorders are highly prevalent in autism and are something we go after right away, because none of us obviously function well if we're not sleeping well, and they can contribute pretty directly to these challenges. So there's not a lot of data in terms of longitudinal about these problems, aggression and self-injury or challenging behaviors generally in this population. There's a little bit that I have here that self-injury in autism seems to be fairly persistent, unfortunately, for those who develop it. So this was one study that showed, over the course of 3 years, from a median age of 10, about 80% persisted with their self-injury. And this is another study that was looking at intellectual disability, so not kids with autism, but another developmentally delayed population, and actually found increasing rates of self-injury through childhood and up to age 30 and 40, and then a decrease with kind of significantly older age. So that's not encouraging. So in other words, time does not heal. We need to intervene. So what's the impact of these problems? So I found this, very interesting, and it's certainly what we observe in our clinical services, which is that if for a family that has a child or an adult who's engaging in these behaviors, this is the biggest problem. They're like, oh, the autism, we can deal with that. I can't deal with this aggression and self-injury. And that's what was shown in these studies. So it's a bigger problem than the general diagnosis itself. This was another look at longitudinal, just showing that these problem behaviors remain heightened compared to the typically developing and compared to the intellectually disabled samples. So this is a particular problem. It's certainly a problem across the spectrum, but it's a particular problem for the more challenged or more severe end of the spectrum, who are often minimally verbal. There's not a clear definition of minimally verbal, but most of us use 10 single words or less. That's minimally verbal. So they have significant communication problems. And so that inability to report their distress and kind of adjust to their environment creates this situation where then these problems often seem to come out of the blue, as parents will say. And then that generates a whole host of problems that follow that I'm going to talk about a little bit. So when a youth is engaging in these behaviors, and they're coming without warning, what you see then is they start to be in increasingly restrictive educational settings or excluded from education, which is what they need most. They stop going out into the community, no grocery store, not out to the restaurant, et cetera. This is, of course, in a pre-COVID world. You start to, of course, see high utilization of psychotropics, hospitalization, out-of-home placement. So this kind of starts a whole cascade of issues and problems. And so those are all very important, but something I like to point out is really the worst effect of this is that it affects the child's development. It potentially keeps them from reaching their potential. So I think it's the unmeasured effect of having these behaviors. And so I want to try to display this to you that, so here, let's say here's a child and this is their potential developmental trajectory. This is like the best they could do, their highest functioning, whatever their deficits are. And so here they are at 4 years, they're going along their trajectory. And then at 4 years old, this child with autism starts to engage in self-injury in their preschool, not a special preschool, just their kind of regular preschool. And they start biting themselves a lot. This is highly distressing, of course, to the staff, to other kids, and everyone's nice, but the child is kicked out of the preschool, which happens all the time. So they're kicked out of their preschool. So then they spend, 6 months at home, not engaging with peers, not having that stimulation, maybe 12 months at home while the parents scramble to try to find somewhere else for the child to be. And so they start losing out on this developmental trajectory. So then here they are at 7 years old, and they're in public school, and the self-injury progresses, and now they're larger, and maybe they start to engage in aggression also, and they maybe they're engaging in aggression and their self-injury gets worse, and it's so distressing to look at that the family stops doing the things they typically do. They stop going to the grocery store with the child, they stop going to restaurants, etc. So the family's world shrinks and the child's world shrinks, and again, stimulation, opportunities for social interaction, etc., shrink. So then we see a further bending downward of the potential developmental trajectory. And so then here we are at age 11, and physical aggression really kicks in for whatever reason, and the teacher gets hurt, and so they get kicked out of they get told not to come to school anymore. Maybe they get sent to the emergency room here at Maine Med. They get hospitalized, and then we try to stabilize them, but they end up in a more restrictive, specialized school setting, or sometimes no school for quite a while. So I think you see the point is that the effect of this over time is a real gap between whatever their potential was and where they are. So that's to me, the real crime of this phenomenon. Obviously, the acute momentary safety risks are a problem, but it's really over time is really the bigger problem. So what do we do about these problems? So here, this is very dense, but just here is kind of in a nutshell, how do you treat challenging behaviors? So I referred to this a little bit before, and it's not the focus of our talk today, but just briefly. So the primary approach is applied behavior analysis, which I referred to before. So that's figuring out the function of the behavior and what is maintaining the behavior in terms of reinforcement, and then trying to address those things. The other major approach is psychotropic medication, which is a whole nother talk in and of itself. But I'll just say that for these two things, they're both major approaches. Various parts of them have evidence behind them, but neither are perfect by any means. And ABA, something like 30% of assessments are inconclusive about the behavioral function, and so that makes it very hard to move forward. And certainly with psychotropic medication, as you all know, can be significant challenges with side effects and also very inconsistent success. So other approaches include working on communication, treating medical problems, certainly, that could be driving this presentation, working with the family, if those are some of the issues. There is good evidence for parent management training programs. So it's not to manage the parent, but the parent to manage the child. Work on sensory regulation, and for higher functioning folks, work on social skills and social cognitive strategies. And for those who are verbal and higher functioning, there's actually multiple RCTs on CBT for anxiety and autism, for anger management and autism. Now, finding a therapist who is skilled and willing to do that work is still a challenge, but the evidence is there. So hopefully we're climbing that curve from evidence to clinical practice, which unfortunately is about a 20-year curve usually. So those are the basic sort of tenets of how do you treat these problems. So there's an aspect of this I want to talk about that is an emerging concept, and I'm going to talk about it because then the research we're doing relates to this. So the aspect is called emotion regulation. So this is an emerging concept in mental health and psychiatry. So emotion regulation is the ability to monitor and modify your arousal and reactivity in order to engage in adaptive behavior. In other words, it's the process that you go through when you are driving on the highway and someone cuts you off and you would like to engage in them in some non-productive way that might put you at risk, but you take some deep breaths and you calm yourself down and you drive onward. Hopefully that's what we do. That's emotion regulation, right? Something we're all maybe having to do at some level this week as we watch the federal picture unfold. So it involves both intentional, so taking a deep breath, as well as automatic or unconscious attempts to manage your affect. And you can utilize, things you've learned, strategies, or the environment. So picture staff working with a child can supply those strategies to help a person regulate. So in autism, we're seeing increasingly that emotion regulation is a specific deficit for a lot of kids. and adults. And this is emerging, but this may be due to there are differences in cognitive functioning. So executive functioning, the ability to abstract, the ability to be self-aware, to realize that you are upset, is a challenge for many people with autism. So there's accumulating evidence that it's more common and more severe in people with autism than in people who are typically developing. So this is really emerging over the past 5 to 10 years. So what does this look like in autism? Probably what you would imagine. So getting angry and exploding before they even realize why or what's happening can certainly lead right to aggression or self-injury. So, you know, the poor or the lay term for emotion regulation deficits, right, is tantrums. That's what we're talking about. So meltdowns or tantrums, irritability, anger, and then you can see these other features. And so not surprisingly, impairments in emotion regulation are correlate with these problem behaviors, as well as with co-occurring psychiatric diagnoses and negative outcomes. And we were actually part of developing, there's now a measure of emotion regulation in autism, and we were part of developing that as a research network. So that's emotion regulation in autism. So now I want to tell you about our research program a little bit and how we developed it, which is a long story, but just giving you a little bit of it. So about 8 to 10 years ago, you know, we decided to start doing research, and we're starting from zero, no money, no funding, no staff, no nothing. But what we had was our clinical setting in front of us. And at that time, that was a inpatient psychiatric unit at Spring Harbor Hospital, one of 8 units. And it's a highly specialized unit. It's called the DD unit, the Developmental Disorders Unit. And that unit only admits children who have autism or intellectual disability, and they are admitted because they are having these challenging behaviors usually, or are really not functioning due to kind of severe mental illness. So we started with what was in front of us, and that unit, this is what's done there. And so we got a little internal grant from MMCRI. I think it was $20,000 or $30,000. It was enough to get half of a research assistant to help me, and we started some studies. And so the first thing we did was we started studying ourselves, started studying the program. And then the next thing we did is we put together a research network of 5 other, so a total of 6 or 7 other specialty inpatient units that are similar to the unit we have at Spring Harbor Hospital. So these are all specialty child psychiatric units that only treat this population. And at the time, this was most of the ones in the country. There's now about 15 of them. This is a growing kind of area. So we put together this research collaborative, flew people in, had meetings, tried to figure out what we could best study with this this setting. And so this has been a really wonderful experience. Have developed colleagues around the country who we talk clinically about problems, and of course have been doing research together now for 7-8 years. And so what emerged from this was we recognized that in our units, the unique advantage or the thing we had that was interesting from a research perspective is we have the more severely affected population, right? We have the kids with autism and ID who are minimally verbal, who have challenging behaviors, who have low IQ. That's who we have primarily in our units. And that's exactly the population that doesn't get studied. Most of research in autism is on the high functioning population. And there's a whole host of reasons for that. Perhaps number one being, who's going to show up to your study when you say, oh, we have a study, please come 12 times and get assessments and blah, blah, blah. This population is not going to make it. These families are barely hanging in there. So that is perhaps one of the reasons. So that's an important thing in the autism world is most research is done on the high functioning population. So we decided to address that. And so with that concept, we sold that concept to a couple of the national foundations that fund autism research. And we were, very fortunate. And so we launched, and that's led to a study that we call the Autism Inpatient Collection that's now been going 7 years. And we've enrolled over 1,400 kids with autism, confirmed autism, and we've done deep phenotyping and taken biosamples, and we're doing whole genome sequencing. And we're doing we are ourselves, our network of investigators have lots of questions that we look at the data and try to answer and write papers on. But ultimately, the important thing about this effort is it's going to produce a reference collection of data that is going to be housed by the Simons Foundation, which is one of the funders, and made available to any external investigator, any investigator in the world. They apply for access, and it's all de-identified, of course, and they get access. And so this is going to be a resource on severe autism for any investigator to use in the world. And so, of course, that's, more important than our questions, although we've enjoyed doing our research. So that's very exciting. And I think we're going to hit that point probably in about a year. So this is way too much to look at, but these are some of the papers and issues that we have published on from this data set. And so, talking about research development, so we started with that little tiny grant. We got a couple more tiny grants along the way. And then to fund this network, we got an initial grant for about $1 million to fund these 6 sites for 2 years. Became 3 more years for a couple $1 million. And then the last grant was 3 more years at, I think, $3.1 million. So that's kind of the trajectory. I'm going to skip this. And so that's kind of our research where we're trying to look at the big picture, look at genetics, and contribute to kind of the resources for the investigator community. We also have been doing a different line of research within our inpatient unit that relates to our topic today, which is we've been trying to figure out, based on what we talked about with aggression, and we're focusing on aggression, but it can also be applied to self-injury. We're trying to figure out a different approach. So I told you the main approaches are applied behavioral analysis, psychotropic medications, and then a bunch of other things. But what we have noticed is something that we've learned from Wendy and her son Ryan, who live here in Maine, and of course given me permission to show this. And so what Wendy says about Ryan, who we've known for a long time since he was young, he's a man, young man. But what Wendy says about Ryan is, due to his inability to communicate his emotions, to manage his emotions and communicate, he attacks us when he becomes agitated or stressed. This behavior is very unpredictable and often occurs with little to no warning signs. It's happened in our home, his school, in the community, and sometimes while driving a car. It's so bad that we can no longer safely live in our home with Ryan. So this is the picture, and this is a family that high functioning, resources, and yet this is what has occurred and continues to occur. And so the interesting thing here is Wendy gives us a clue as to what is really the problem here, that it's unpredictable and that it occurs with little to no warning sign. So that, what she's saying is the behavior is a problem, a big problem, but it's made so much worse because we don't know when it's coming, right? So we can't prepare for it. We can't lower the risk of it occurring. We are walking on eggshells all the time. And because of this, that's why we can't go to the grocery store and we can't go out to dinner and we can't be in a regular school setting, because you never know when it might happen. So you have to plan for the worst at all times. Kind of like your 14-month-old toddler, where you're constantly wondering, are they going to topple over and hit their head in the house, right? Like it's the same kind of thing. So this is a big problem. So we decided to focus on this. So how can we create more predictability and try to get some warning of these behavioral episodes? So our what we thought we could use is physiologic arousal to try to get an objective measure of what the person is experiencing, because we're particularly focused on people who don't communicate well, and see if we could relate their physiology to the behavior that is coming in a very short time frame. And so our conceptual model was that here's an individual, they're kind of at their autonomic or physiologic equilibrium. There's some kind of stimulus, what doesn't matter what it is, they experience distress, and so they experience physiologic arousal. So heart rate goes up, starts sweating, sympathetic drive goes up, etc. As we talked about, there's variable emotion regulation ability in autism and deficits there. And so if they're not able to regulate, they might progress to aggression or self-injury or a tantrum or some other challenging behavior. But we're using aggression here as our kind of prototypical thing. Or if they're able to regulate or tolerate it, then they don't aggress. And if they can regulate, they can return to equilibrium. But if they can't, then they may progress to this kind of the symptom, what we see, the challenging behavior. There's also a sub question here, which is, does the behavior itself help them maladaptively, help them return to equilibrium? So in other words, is part of engaging the behavior a maladaptive attempt to re-regulate, right? So an adaptive way to regulate yourself is to take deep breaths because no one gets hurt. A maladaptive way to regulate yourself, if this is true, which is a hypothesis, would be to hit somebody or to scream and yell and have a big tantrum. So, in a simple study by my colleague at Northeastern University, you definitely can see a relationship. So this is one individual, a relationship between physiology and behavior. So in this example, we're going across time. Here's an individual at baseline. This is just heart rate, simple measure. So they're in the 70s. We see a rise in heart rate, and then they engage in an aggressive episode. So a large rise there. Then there's a decrease in arousal, and then they're back to their baseline level over whatever this time period was. And then giving a further example, I talk about arousal, but you can also see a downward deflection in arousal. So some individuals will actually decrease their arousal level before an aggressive episode, and then again, a return to baseline. So the interesting part here, right, is, we all know this, right? If someone's upset and they're aggressive, their heart rate's going to be high. What's interesting is this part. It's the rise before you actually see the behavior. Because picture what's going on here is a person who doesn't communicate well is sitting in a classroom, let's say, and they're doing their educational tasks, and they look fine, but they're not fine. Their heart rate or their physiology is elevating, and they're about to, hit their teacher. But you don't know that because they look fine. So then it's out of the blue, but it's not out of the blue. We just can't see what's going on. Sorry. So we decided to take this head on within our research network. And so what we've been doing is a large research study to try to get at, can we measure physiology and can we relate it to the behavior that follows? And so the way we've been doing that is this is a wearable biosensor, looks like a watch. And what this measures is heart rate variability, motion, so it's an accelerometer, but it also measures electrodermal activity, which is also called galvanic skin resistance, which is the little bit of electric current that's running over your skin all the time, which is determined by how much you are sweating, which is determined by how much your sweat pores or glands are open, which is controlled by your sympathetic nervous system. So this is a measure of sympathetic nervous system drive. So in other words, it's a way to measure fight or flight kind of response. So that's electrodermal activity. So we're getting all those data streams from the kid wearing the watch. That is going by Bluetooth to be recorded in a device that our research assistant is holding. And then the research assistant is coding a separate stream of data, which is what is the person's behavior. So we're getting their physiology, and then the research assistant is coding aggression or not, self-injury or not, right? So we're measuring those two things simultaneously, and then we are transferring the data to our colleagues, Dr. Goodwin at Northeastern University, and he has expertise in artificial intelligence, and so he then runs the data to try to develop a predictive algorithm based on this on these two streams of data. And so we did a pilot study that we published in 2019 on 20 participants. And just in this pilot study, we got 84% accuracy to predict a challenging behavior episode, aggression, 1 minute before it happens. So that was our pilot study. So then we've done the multi-site study across our research network. So then we worked on the analytics, the artificial intelligence, and we actually got that up to 95%, 3 minutes ahead of the event. And then finally, we're doing now a multi-site study, and we have data now on 70 kids, and the results are looking basically the same as the pilot study. So that's encouraging. However, so this sounds really good, and it's encouraging, but this is all offline. So in other words, we record the data, then we look at the data and run the algorithm and see if we can predict in retrospect what would have happened. And that's the results I'm showing you. The next step, which we're launching this winter in our research network, is to do real-time prediction. So in other words, take the algorithm. So again, we have the child wearing the watch, research assistant, same thing, coding. But in real time, where the plan is to feed that data up into the cloud, where our algorithm that we've already developed in the prior study is running, process it in real time, and then send an alert to the staff person with a prediction of the risk in the next 3 minutes of this behavior occurring. So we're bringing this into a live system, which, as you can tell, it's not easy. That's a big step. So that's our next step of research. Okay, so that's the end of that. So then I just wanted to give you a further sense of the kind of research program and stuff we're doing. So I'm the PI for a number of studies. So I told you about this autism inpatient collection. I just told you about this PREDICT study, which is funded by the Department of Defense. And then we also are about to launch a study on therapeutic horseback riding in autism, which has been shown to have benefit, but no one knows why. And so we are going to, again, look at physiology and try to get at what's the mechanism that produces this improvement that we see sometimes. And that was funded by the NIH. So we also, a goal of ours is to grow our research program and have multiple investigators. And so that is happening, which is exciting. So we have Dr. Taylor, who was a postdoctoral fellow with us for 3 years and now just became a faculty member. And she was recently awarded a career development grant from the NIH. All based on work she did here. So that's very exciting. We also just had a child psychiatrist join us from Brown, who is half-time research, and she's very interested in features of depression and autism. So she'll be applying for an NIH Career Development Award, which is also called a K Award. And finally, we have Dr. Pedersen, who's been with MMCRI for a while. She's a social scientist, and she's studying anxiety and family relationships in autism, and will be applying for a K Award. So that's our growing research investigators, and then we have a staff of 5 research personnel, and we're all under the Center for Psych Research, and the director is Susan Santangelo. So I'm just sharing this because I wanted to give you a sense. I think Dr. Odolini, when she asked me to give this talk, wanted me to talk about the research we're doing and aggression, et cetera, but also just try to give a sense of how do you develop a research program right here in Maine, and that it is possible. It's not easy, but it is possible. And, my message to you about this is, we all start from zero, no funding, no nothing. start with what you have. You have your clinical services in front of you and you have questions, and then you just start building from there. And if you're very lucky, which we've been, you're able to pursue this. So that's essentially the end of my talk. I did want to share some resources because I know many of you work with this population, encounter them in pediatrics or other settings. So I wanted to give you some resources to deal with these challenges. And then we'll have time for questions. So what does MBH, Maine Behavioral Healthcare, the organization I work for, what do we do for this population? So we have developed a whole continuum of behavioral healthcare for this population, and this is pretty much all for youth. We have an outpatient center for autism and developmental disorders called CAD, which is in South Portland, and that's an outpatient building. And so there we have a clinic, multidisciplinary clinic with child psychiatry and developmental peds, and we do those disciplines and psychotherapy and case management and behavior analysis. So the goal of that clinic is to treat the mental and behavioral health challenges for this population. We also have some intensive treatment programs. So we have what's called a day treatment program for school-age children, as well as a preschool program. And now we have a toddler program that we do in people's homes. And those are all to treat these challenging behaviors and meet their educational needs and help kids develop. Then at the hospital, at Spring Arbor Hospital, we have the unit that I referred to, this acute inpatient psychiatric unit that's a very specialized unit. And the focus there obviously is to treat very severe behaviors and mental health problems. And then just recently, we started a partial hospital program. So that's a program that's 5 days a week, 6 hours a day, for maybe 3 weeks. And so people come and receive treatment short term, it's intensive, and then they leave the program. And we're actually running that virtually right now. So that's the services that we offer. So in summary, on what we've discussed, individuals with autism can develop serious behavioral challenges, and these can be more impairing than the autism itself per some families. The parents report that it is really the unpredictability and lack of warning that is the biggest problem. So our initial studies suggest that maybe we can use physiologic arousal, these physiologic changes, with other data to predict these episodes. And we need certainly more research on this topic, but just generally, we need better approaches to this problem. So we're trying one approach, but because ABA is good and medication is okay, but there are many kids and adults where that doesn't do it. And so we need other approaches. And then finally, I tried to give you a little bit of an example of how we developed our research program, which was all through MMCRI and supported by MMCRI. Just brief acknowledgements, co-investigators in our research network, as well as people here at Maine Med and our funding organizations. For some resources for you folks, so I was part of, we had a group working through ACAP, the American Academy of Child Adolescent Psychiatry. We put together this parents medication guide in autism, but really I would call it a parent and provider medication guide. So there's good information in here about how you might think about medication in terms of different problems in autism, whether it's ADHD or something else, and it's free and you can download it from ACAP. And then my colleague, Dr. McGuire, developed a practice pathway for primary care for working on irritability and problem behavior in autism. And so gives kind of an algorithm and pathway of how to think about that and treat it. So those are two resources. And then finally, people often ask, well, the services here in Maine, how do you get into them? So this is the referral pathway. So for our hospital-based programs, the GD unit and the partial hospital program, you contact our referral coordinator, Kate, and these are the folks for the other programs, the day treatment for school age, preschool, toddler, and then our outpatient clinic, CAD. So these are the path to do that. So thank you very much. Happy to take questions. And I'll leave this slide up in case people want to see it. No questions so far. So let me encourage you to use the chat for questions, or if anyone here in the room has a question, just raise your hand. Okay. Whoop. Now we have a few. Let's see here. Just trying to sort through people's chatting versus questions. Okay, so Genevieve Whiting says, regarding the various CAD programs, do providers need to select which program, or will CAD screen that? I think yeah, I mean, it's helpful if you have an idea which program, but we can obviously guide the referral into the right program. So if you send a more general referral, we can certainly do that. Let's see what else we have. Yep, there's a statement from Eileen Poulin that she knows someone who works at a local place doing biofeedback for kids and young adults with autism, and that has seemed helpful. There is some evidence in typically developing kids for biofeedback being potentially helpful, particularly for anxiety. I am not aware of evidence in autism for youth, so that doesn't mean it's not helpful, but I'm not aware of evidence for that intervention. Any questions here in the room?
I have a question. So in those few minutes, the few minutes before when somebody's heart rate's going up, and so what would you anticipate would be interventions that you might try?
Okay, great question. So the question was, it's a great question because it's the so what, who cares? So if you can detect the heart rate or the physiology going up before the behavior occurs, what do you do? And I didn't speak to that, so thank you. And we have gotten that question before, certainly, because if you don't work in this world, 3 minutes or even 1 minute doesn't sound like very much time. In this world, it's a lot of time. To have a minute or 3 minutes of warning of a potential challenging behavior is a lot of time. And so what you would do then is if there is a known strategy that is helpful to the child to de-escalate, so there's a series of things you could do. So the first thing you want to do, obviously, is try to de-escalate the person's arousal level. So if there's a known strategy for that seems to work, then you do that. If there isn't a known strategy, then you now have the perfect setup to test various strategies. We think this is about to occur. Let's try this. Did it occur or not? So it gives you your own little experimental design right there clinically to work with someone. The other things you can do is make the environment safer, remove people, remove problematic objects. You can reduce demands. So very often this starts to happen when you're placing demands on a child, whether it's to tie their shoes or do math problems or whatever it is. So you may choose to reduce demands and then help them try to re-regulate with various strategies. The strategies we use typically in this more challenged population are typically not so much talking, which is the strategy most of us use with each other to try to de-escalate. It's usually more physical strategies. So it's more, let's step over here, let's bounce on a ball, let's take a walk in the hallway. It's usually less talking and more activity is usually the kind of strategies that we use. But it's highly particular to the individual. So that's what you have to figure out. But this is, so it's a really good question. This is part of why we think that if we know it's coming, it'd be great if it never came, but if we know it's coming, at least then we can do these things. And then hopefully over time, teach the individual to recognize when they're starting to have an elevation in their physiology, and then have them, that's the holy grail, right, is they self-recognize, and then they self-regulate with our help or not. And that's the goal for all of us, right? Okay, so question was, does CAD need a diagnosis of autism before referral? So the answer is yes. So at CAD, our focus is not on diagnostics. It's on evaluation and treatment of these challenges in mental health. So typically kids who are being referred to CAD for the outpatient program or other programs, they've already been diagnosed with whatever their developmental challenge is. So that is the case. And then we have another question. Talk to us about enrolling kids in the writing study or the other studies. So the writing study was supposed to start last March. So as you can imagine, that didn't happen. And so we're hoping we can start it in February. But so we're figuring that out in relation to COVID, and we'll be doing it at Riding to the Top in Windham, which is a local therapeutic horseback riding center. You can certainly contact me for enrollment information in that study. We have some materials out there, but we haven't put it out in a major way because we haven't started the study yet because it was delayed. But happy to, if you want to contact me, or I'll put you in touch with our research coordinator. Yeah. Oh.
Just a question for those of us who are still training and thinking about careers and research down the road. And I know you talked about this a little bit earlier on, but how do you go about finding research collaborators for parts of the question that you have that you don't have the skills or the know-how to actually investigate yourself?
Okay, great question. So the question was, as you're coming out of training or you're at the end of your training, how do you find research collaborators to work with who, have knowledge and expertise, et cetera, that you don't have yourself? It's a great question because it really is, team science, and you really can't do it on your own, really, for almost anything. And so the answer is there are some official ways to find collaborators, or some formal ways. So the Tufts CTSI, Center for Translational Science, is actually their role. So we're, that's a resource for us. We're part of Tufts Medical School, of course, and they, on their website, they have their role is to connect people and facilitate and enhance research. And so they actually have a whole formal process of, it's actually as simple as you can kind of write into the website, here's what I want to study, here's what I'm interested in, I need help with data analysis or whatever it is, and they will help connect you with resources or collaborators. So that's one formal way to do it. Another formal way here in Maine is MMCRI has several research navigators. There's a research navigation program, and that program specifically is oriented toward residents and kind of junior or early faculty who are trying to develop these things. And those navigators, they're great, and they sit down with you. What's your question? How do you want to approach this? Have you thought about this? Have you thought about this? Okay, well, John over here, he has expertise in that. I think you should talk to him. So that's definitely helpful. So if you go on the MMCRI website, there is a navigator page. And again, you can just write in, here's what I'm interested in, and they will get in touch with you. So those are two formal mechanisms. And then informally, it's, once you get going, you start publishing and giving talks, et cetera, you people, you meet people and you start developing collaborators, and that's the other way. Okay. So I think we're at the end of our time. There was a question, will the slides be posted? And I believe they will. Yes. Great. And I think that was the last question. So thank you very much for your attention. Have a great day.